Hello class, we will continue our respiratory lecture with chapter 26, Concepts of Care for Patients with Non-Infectious Upper Respiratory Problems. Now the respiratory chapters include chapters 24 through 29, therefore your test on the 30th will cover these chapters. Please do not wait until a day or two to start studying because it can get overwhelming with all these heavy chapters. So listen to the online lectures and complete the learning objectives after each chapter. Complete the practice quiz questions in SharePoint. The notes you take in class for those who are face-to-face. And I want you to take what I say in class seriously. Review thoroughly the charts and boxes that I refer to as your friend, and contact me with questions or concerns. The priority concept in this chapter is gas exchange. The interrelated concepts in this chapter are tissue integrity, and this is part 1 of chapter 26. These are the learning objectives that I would like you to accomplish at the end of chapter 26, and all these learning objectives are related to part 1 of chapter 26. So after you have listened to part 1, I would like you to complete the learning objectives. In chapter 24, we discussed that the nose and sinuses include the upper respiratory tract, and this picture portrays the parts and structures of the nose and sinuses. Okay, we will be discussing upper airway obstruction. We also mentioned in chapter 24 that gas exchange is the transportation of oxygen to the cells and removal of carbon dioxide or CO2 from the cells, which is ventilation. The nursing priority for patients experiencing upper airway problems is to promote gas exchange. How does the nurse do this? By ensuring that the patient has a continuous patent airway. So when a patient develops upper airway obstruction, the airflow through the nose, mouth, pharynx, or larynx is interrupted. That is, the continuity of the airflow process is broken. Once gas exchange is inadequate or impaired, obstruction can be a life-threatening condition. Therefore, it is imperative that the nurse or healthcare provider recognize this problem early to prevent complications, which includes respiratory arrest and death. So what causes upper airway obstruction? Some causes include edema of the tongue, and this can occur from surgery, trauma, or angioedema. And angioedema is a painless swelling under the skin, which is triggered by an allergic response to a drug, pollen, food, or animal dander. It can also be caused by occlusion of the tongue, and occlusion is blockage or closing of a blood vessel or organ. For example, loss of gas reflex, loss of muscle tone, unconsciousness, and coma. Upper airway obstruction can also be caused by laryngeal edema, and this is from any cause such as smoke or toxic inhalation, local or generalized inflammation, allergic reactions such as anaphylaxis reaction. It can also be caused from peritonsillar and pharyngeal abscesses, head and neck cancer, thick secretions due to poor oral hygiene, stroke and cerebral edema, facial, tracheal, or laryngeal trauma or burns, and also from foreign body aspiration. And if there's a foreign body, this obstruction may be managed as an outpatient or in the ED. So as we mentioned earlier, that early recognition of airway obstruction is vital to prevent complications. Therefore, prompt care is necessary to prevent a partial obstruction to progress into a complete obstruction. So we don't want the partial to progress to complete. So we have to act early to prevent that and save the patient's life. Assess the obstruction, whether partial or complete. Diaphoresis, tachycardia, elevated blood pressure, and anxiety are symptoms of partial obstruction. Assess the patient for hypoxia, hypercarbia, restlessness, increasing anxiety, sternal retractions, changes in consciousness, choking, confusion, stridor, cyanosis, as these are signs of complete obstruction. Use pulse oximetry or end-tidal carbon dioxide or EtCO2 or partial pressure end-tidal carbon dioxide PeTCO2 to continuously monitoring the gas exchange. We discussed these non-invasive diagnostic tests or assignments in part 2 of chapter 24. The nurse or healthcare provider will assess for the cause of the obstruction. We mentioned earlier some causes include tongue edema, tongue occlusion, laryngeal edema, etc. And so the nurse or the healthcare provider will assess what caused the obstruction and take action to save the patient's life. So if the obstruction is caused by problems with the tongue or excessive secretions, then the action would be to slightly extend the patient's head and neck and insert a nasal or oral airway. Then suction to remove obstructing secretions. If the obstruction is caused by a foreign body that is unable to remove by clearing the oral cavity manually, then perform abdominal thrusts. And you guys have done this when you've done your CPR. See figure 26-1 on page 517 for abdominal thrust maneuver. Upper airway obstructions sometimes require emergency procedures to be done to improve gas exchange if the object causing the obstruction cannot be removed quickly. And so some of these procedures include a cricothyroidotomy, also known as cricothyrotomy, which involves making a small horizontal incision or a small opening temporarily through the cricothyroid membrane between the thyroid cartilage and the cricoid cartilage. See figure 24-3 on page 475 for the location of the cricothyroid membrane, thyroid cartilage, and the cricoid cartilage. Another emergency procedure for airway obstruction is a tracheotomy. And this is a surgical incision into the trachea to create an airway to maintain gas exchange. We discussed in chapter 25 regarding a tracheotomy, tracheostomy, and we talked about tracheotomy, and the doctor has to first create a tracheotomy and then do that tracheostomy. So the tracheotomy is a surgical incision into the trachea to create an airway to maintain gas exchange. And again, this procedure can be done at the bedside, but it is best performed in the operating room or either under local or general anesthesia. Now, a tracheostomy is performed if the patient cannot be easily intubated with an endotracheal tube. Tracheostomy is the opening that results from a tracheotomy. Also, patients who is under ventilator due to upper airway obstruction or respiratory failure may require a tracheostomy after 7 or more days of continuous endotracheal intubation. Endotracheal intubation is performed when there is pharyngeal or laryngeal edema expected and can be done before the edema started. How this procedure is done? It is performed by inserting a tube into the trachea by the nose or mouth by a physician, anesthesia provider, or specifically trained personnel such as a certified registered nurse anesthetist. We will be discussing sleep apnea, obstructive sleep apnea. And on here you see the term sleep time um, hypopnea or hypopnea, and that is breathing disorder that occurs, that causes shallow breathing episode. That's what that word means. Okay. Obstruction sleep apnea or OSA, and you'll hear me refer to OSA, so that's obstructive sleep apnea, is a disorder that occurs during sleep. While the individual sleeps, the muscles become relaxed, and the tongue and neck structure also become displaced, and breathing is interrupted. That is, the individual stops breathing for at least 10 seconds. And this can occur for a minimum of 5 times in an hour. After 10 seconds or more, the individual wakes up and corrects the apnea by restoring breathing. However, as the patient or individual resumes sleep, this cycle starts over again. OSA decreases gas exchange due to the restricted breathing. This lowers the blood oxygen level. The arterial blood oxygen saturation levels is less than 80% due to the apnea. And you can see if they don't get that oxygen, how that patient can die. However, OSHA decreases gas exchange, which I just said that. It also increases blood CO2 levels and decreases the potential hydrogen or pH of the blood. And this is due to the hypopnea, which I said that hypopnea is a sleep breathing disorder that causes shallow breathing episode. It also causes the apnea or snoring. This cycle pattern of disrupted sleep. Let's start that over again. OSA increases blood CO2 levels and decreases the pH of the blood, and this is due to hypopnea, apnea, or snoring. This cycle pattern of disrupted sleep interferes with the circadian rhythm, and the individual has daytime sleepiness, unable to concentrate, morning headaches, and becomes irritable. Some increased risk of chronic long-term OSA include stroke, hypertension, cognitive deficits, weight gain, diabetes, pulmonary, and cardiovascular disease. So what causes sleep apnea? All these listed here, obstruction by soft palate or tongue, and I'm not going to read all of them. You can see these: obesity, etc. These are some etiology or causes of OSA. A congenital variation from the norm in the oral cavity structures, the pharynx or the neck in adults, place them at increased risk for OSHA as well, or OSA. Adults with the genetic disorder of achondroplasia or dwarfism has a high incidence of OSA. So this is the genetic risk. So adults with genetic disorder of achondroplasia or dwarfism has a high incidence of OSA as a child and adult. And also sudden infant death, also when a child born with the achondroplasia, they can have their sudden infant death. And if they don't have that, as they grow up as a child, they're at risk for having obstructive sleep apnea. Sleep apnea also occurs in children, and the most common cause is adenotonsillar hypertrophy. And this is the abnormal growth of the pharyngeal tonsil, which is the adenoids, they just call that the pharyngeal tonsil, and also the palatine tonsils, which is really the tonsils. So, however, the majority of children have mild symptoms and many of them outgrew the condition. If it is untreated, the children may develop attention deficit disorder, behavior problems, poor academic performance, and cardiopulmonary disease. So we have to get that treated in children. Okay. So because the incidence of OSA is underreported, the actual incidence of this condition is unknown. However, the prevalence of OSA among adults in affluent countries, that is, prosperous or wealthy countries, has an estimate of 9% to 38%. This condition seems to affect men more than women, but the incidence greatly increases in both men and women after 65. And that is true, that I live in witness that it affects men more than women. My youngest son has all the signs and symptoms of obstructive sleep apnea, but he would not get tested, but I know he has that. And so when he had the COVID early up in the year, and his O2 sat was dropping, went down to 74 and things like that, I did talk to the doctors about putting him on a BiPAP because I knew that he had sleep apnea. It wasn't confirmed because he would not go, but he has all the signs and symptoms. And when he went on that BiPAP, he was able to bring up his O2 sat. He was able to come home without oxygen. My husband also had sleep apnea too, and they're both men. And I've seen a lot of men in the hospital. I've seen women, but a lot of men with that condition. Okay. So now we're going to move on to the assessment of patient with sleep apnea. So as usual, assessment starts with history taking. Therefore, to assess or recognize cues for sleep apnea, the nurse or healthcare provider would ask the patient or client if he or she has persistent sleepiness during the daytime, ask about heavy snoring, falling asleep while performing tasks such as using the computer, reading, or driving. Although it's in extreme cases, patients may also fall asleep while eating or anytime he or she sits down. And believe me, when my son sits down, he works nights, but sometimes he's not working, and I know when you work nights and things like that, it throws off your circadian rhythm. But sometimes he will be just sitting there, he's off, and he will fall asleep. Therefore, ask the patient about this as well, if they fall asleep while driving or eating. Ask the patient if he or she has been awakened by their own snoring or family members ever observed the patient disturbed breathing pattern while asleep. This pattern includes breath that becomes further apart than a period of not breathing, which is called apnea. And I remember one time my granddaughter said, "Gee, Mama, come. Daddy's not breathing." And she observed that. So this pattern includes breath that becomes further apart than a period of not breathing, which is called apnea, followed by chest and abdominal movements that leads up to gasping and snoring, with the patient waking up partially to temporarily correct the obstruction. For the patients who have OSA, ask if they use over-the-counter sleep medications or increase evening alcohol consumption in order to get a deeper sleep. Because most patients with OSA experience some degree of gastroesophageal reflux disease or GERD during the night, ask the patient whether he or she often awakes with heartburn, stomach contents in the mouth, or a burning, choking sensation with coughing. Also asks how often this occurs to determine the frequency of these episodes if it's reported. Some possible causes of GERD in patients with OSA include the strong abdominal and chest movements during an apnea episode, overeating, eating or drinking close to bedtime, and lying flat on the back while sleeping. Physical assessment includes signs and symptoms, so assess the patient's general appearance, which includes the height and weight. And we said that weight is a factor, it's a risk factor for developing this disease. So you will assess the patient's general appearance, which includes the height and the weight. The majority of adults with OSA, as I said, are overweight, and this is a contributing factor for OSA. Examine the jaw, external neck, and chin. We mentioned earlier that a shorter neck is one of the etiology of OSA. However, a retracted lower jaw and smaller chin is also associated with this disorder. Examine the oral cavity and throat. Here, the nurse or healthcare provider is checking the size and shape of the pharynx and uvula, and the thickness of the tongue and its position. Also check to see if other structures are enlarged or swollen, such as the tonsils, adenoids, pillars, and soft palate. Because patients with chronic OSA may develop cardiovascular changes, particularly hypertension, assess the patient's blood pressure, heart rate, rhythm, and pulse oximetry. Which, of course, when you use the pulse oximetry, you're going to assess the O2 sat. That's what that means. Ask the patient what medication he or she is taking for hypertension if appropriate. However, if the patient is not taking blood pressure medication, but the blood pressure is elevated, retake the blood pressure at a later time during the assessment and document any persistent elevations. Psychosocial assessment, as usual, I always say that two things you will always experience in nursing, in any area of nursing, is mental health and med-surg. Those are the two, always. So with persistent OSA, the patient can become irritable and have personality changes, such as become depressed and lose interest in social activities. Therefore, ask family members who may be helpful to share some insight in this area of assessment. Ask the patient whether he or she has problems with recalling or other memory problems, such as concentration. Also ask about energy level and the ability to stay on task when working or studying. So diagnostic assessment is performed to determine a diagnosis of sleep apnea, and these include stop-bang, sleep apnea questionnaire. And the stop-bang, these are some new assessments that they use to determine. So the stop-bang is like, the S is for snoring, and the T is for tired, O is observed, the P is for pressure, the B is body mass index, more than 35, they're asking these questions, and the A is the age, and the N is neck, and G is gender. So that's the stop bang, sleeping apnea. And I was going to put the questionnaire up here, but it was too much for the PowerPoint. So I will have that in class for you guys to see. Or as a matter of fact, I'll upload it so you can see the questions. Others are called Epworth Sleepiness Scale, the Pittsburgh Sleep Quality Index, and the Multiple Sleep Latency Test. So these are the questionnaires that they use. Other things to diagnose sleep apnea is sleep study. There's a sleep study at home. Also polysomnography and monitoring devices. So obstructive sleep apnea is not diagnosed by just using one blood test or imaging method. However, specific tests may be ordered after the patient is diagnosed with OSA just to determine if there are any underlying health problems that may predispose the patient to this disorder. The patient would complete one of the questionnaires mentioned um, to determine the sleep quality and extent of daytime sleepiness. So, okay. And so we talked about the stop bang, and we said that they were the Pittsburgh sleep quality one. So they will um, complete one of those questionnaires, whichever one the provider want to use. If the results of any of the questionnaires determine that the patient has OSA, then a less intrusive at-home sleep study, and I guess it's intrusive because intrusive by asking them questions. So if any of the results show that they may have OSA, then a less intrusive at-home sleep study is prescribed for the patient. The home sleep study consists of the patient sleeping in his own bed with electronic monitoring of respiratory rate, chest movement, eye movements, and other muscle activity. After the home sleep apnea study and the result is positive for sleep apnea, and also the desire of the patient to perform more studies, a more definitive overnight sleep study is ordered, and the patient will be in the hospital overnight. And this is called polysomnography. During this study, the patient is directly observed during a full sleep cycle while wearing different types of monitoring equipment to evaluate the depth of sleep, type of sleep, respiratory effort, oxygen saturation, muscle movement, and carbon dioxide exhalation, because we said that that is increased during person with sleep apnea. Monitoring methods and devices include an electroencephalograph or EEG, an electrocardiogram or ECG, or an electromyography or EMG. And also the patient will have a pulse oximetry as well. The priority collaborative potential problem for patients diagnosed with obstructive sleep apnea is persistent poor gas exchange and hypoxia due to the abnormal sleep pattern. This is demonstrated by cardiovascular, metabolic, and neural function. So what are some of the interventions for sleep apnea? So to improve gas exchange, duration of restorative sleep, and hypoxia in these cohorts, non-surgical and surgical management interventions are implemented to correct the problem. However, the management depends on the severity of the problem as well as the patient's willingness to participate in the treatment plan. Because if the patient is has severe sleep apnea and the CPAP and things would not help, surgery will be, and I've seen that where a patient will have to do surgery first because of waiting so long. So before the doctor resort to surgical measures, non-surgical interventions are used to correct the sleep apnea. Surgical management or interventions are implemented when there is an anatomic related cause, non-surgical interventions failed, or for severe cases of OSA. So let's start with the non-surgical management. Earlier we mentioned some causes of obstructive sleep apnea, such as obesity or smoking. Therefore, the healthcare provider will start out with reducing the obstruction. For example, if the obstruction is due to obesity, encourage a patient to lose weight. If it's smoking, then to reduce or quit smoking. Changes in sleeping position. Encourage a patient to change position from lying on the back to the side or his or her stomach. Lying on the right side. If they sleep on the right side, it reduces snoring and encourages blood flow. We mentioned that weight loss earlier. We mentioned earlier that weight loss can correct mild sleep. Weight loss is a problem that contribute to sleep apnea, and this can be corrected if the patient lose weight, and that will improve sleep apnea and improve gas exchange. But it only corrects a mild sleep apnea when they lose the weight. Position fixing devices may prevent the tongue from becoming displaced or block the airway, thus reduce the obstruction. A position fixing device includes the patient wearing a special device around the waist to assist the patient or keep the patient sleeping on his or her side. It uses Velcro tactile feedback technology that fully vibrates when the individual starts to roll over to sleep on his or her back. This device alerts the body to change position without waking up. That is cool. The use of an oral appliance known as maxillomandibular advancement can improve airflow by supporting the lower jaw in a more forward position, and is particularly beneficial to patients who have a retracted lower jaw. In chapter 25, we discussed non-invasive positive pressure ventilation, which is NPPV, and we talked about the CPAP, which is continuous positive airway pressure, and we talked about the BiPAP, which is the bi-level positive airway pressure. And so with sleep apnea, CPAP is used, the continuous positive airway pressure, to hold open the upper airways or to keep a collapsed lung open. And remember again, the CPAP, the lung is already collapsed, and they're keeping it, trying to keep that collapsed lung open. Whereas with the BiPAP, you're preventing the lungs from getting collapsed. So anyway, the CPAP is the most common type of non-surgical management for OSHA, OSA. I don't know why I say OSHA, that's the OSA. However, keep in mind that the BiPAP is also used to keep the lungs from collapsing. Figure 25-9 on page 503 portrays a nasal continuous positive airway pressure with a tight seal covering the nose and mouth. Figure 26-2A on page 519 shows an automated CPAP machine and monitor. And B, which is figure 26-2B, shows a patient wearing the nasal pillow without prongs connecting to the CPAP machine. Stress to the patient the importance of adhering to this regimen to assist with this disorder. Also provide in-depth educational material for the patient about OSA. Drug therapy. Drug therapy to treat OSA has been unsuccessful. Sedatives to promote nighttime sleep makes the condition worse. And stimulants used to promote daytime wakefulness have too many side effects and really don't contribute to restorative sleep in this cohort. I remember about modafinil. Modafinil was one of them that had the least side effects. Another name is Provigil or Tenance, compared to the other stimulants, and the Food and Drug Administration approved that. But now they're not using that anymore because they said they have too many side effects. So I guess they're not doing that. So drug therapy is not one of the non-surgical management anymore for treating a patient with sleep apnea. So don't remember, if you see that, drug therapy is not the correct answer. So the non-surgical management is, to recap, reducing obstruction, changes in sleep position or weight loss, position fixing devices, CPAP, and drug therapy. Drug therapy is not in it anymore. For surgical management, this is implemented when non-surgical management fails, such as the patient is not able to tolerate the CPAP, or the CPAP does not improve the apnea, or for severe cases of OSA. However, the patient must first undergo a thorough endoscopic examination under deep sedation to determine which problem or problems caused the OSA before surgical intervention is performed. Anatomic structures or changes in anatomic features that result from oropharyngeal muscle relaxation may be revealed from this examination. Then surgery is planned according to the specific cause or problem. So what are the surgical interventions? These include implanted stimulations. This is a minimally invasive surgery that helps patients with mild to moderate sleep apnea. Please read that surgery, how they do that surgery, on page 520. Another surgical management include a tracheostomy. However, this is not common. It's not a common surgery to manage OSA at all. Other surgical interventions include, and these are common that I've seen working on the general surgical floor, the uvulopalatopharyngoplasty, or UPPP, and modified uvulopalatopharyngoplasty. These are common, and the modified is a new one. Please read how these are done also on page 520. Post-op care, of course, would focus on maintaining a patent airway, relieving pain and preventing complications. Assess the patient at least every 2 hours during the first 24 hours after surgery. Why? To check for indications of narrowing of the airway or partial obstruction. And how would the nurse know this? The patient will present or show signs of increased respiratory effort. Stridor will be presented. The patient will have stridor, which is the adventitious long sound, or crowing. Drooling or the inability to swallow oral secretions. Oxygen sat will also decrease. The size of the oropharynx will decrease, and there will be a rise in the end-tidal carbon dioxide level, EtCO2. Call the rapid response team if the patient shows any of these signs and symptoms to prevent a partial obstruction from becoming a complete obstruction. Relieving the pain after surgery has a high priority as well, because the oropharynx has a rich nerve supply and is extremely sensitive, and we do not want the size of the oropharynx to reduce. Therefore, administer the pain medication, which is usually ordered parenterally, for the first 24 hours. And parenterally is like IV, IM, or subcutaneously. The pain is best managed when the analgesic is given on a schedule rather than on a PRN basis. Because risk for infection after surgery is common, focus on preventing complications such as potential for injury and bleeding. The oropharynx has a rich supply of blood, and excessive bleeding is possible. So these are pictures of non-invasive positive pressure ventilation. A, the patient is wearing a nasal mask and headgear. B, patient is wearing nasal pillows. And C, the patient is wearing a full face mask. Okay, care coordination and transition management. The majority of patients who use CPAP to manage OSA are on an outpatient basis. Therefore, encourage a patient or client to follow up with his or her primary care physician to evaluate the effectiveness of the treatment regimen. The surgical patients are usually discharged within 2 to 3 days, and at the time of discharge, the pain is usually controlled with oral drugs, and the patient should be able to swallow effectively. Teach the patient to keep the system with the CPAP. One of the objectives talks about formulating a teaching plan for patient that is using a CPAP and a patient who had surgery for OSA. So with the patient with a CPAP, you're going to teach the patient to keep the system clean to prevent infection and maintain tissue integrity. Once there is humidification, fungal infection is possible. Therefore, encourage a patient to use distilled water in the humidifier and to clear the mask, device, or pillows daily using the agents recommended by the specific manufacturer of the device. To reduce infection, instruct the patient not to share pillows or tubing with other people. For patients who had a surgical procedure for OSA, the nurse would teach them to assess the oropharynx for bleeding, swelling, or indication of infection, like a fever. Instruct the patient that a small amount of blood mixed with saliva or mucus during coughing, and I made a mistake there. So instruct the patient that a small amount of blood mixed with saliva or mucus during coughing is normal, but excessive bleeding, large clots, or bright red blood may indicate serious problems and must notify the surgeon immediately or go to the ED if these symptoms occur. Also teach a patient how to examine his or her throat with a mirror twice per day and assess its internal size by comparing it with coin sizes. And narrowing of the throat and difficulty swallowing with or without pain and the presence of drooling are indicative of swelling and possible airway obstruction. Therefore, instruct the patient to go to the ED immediately if these occur. Pain is expected to decrease daily, and the patient should be able to tolerate swallowing without any difficulty. Therefore, encourage a patient to drink cool liquids, keep the area humidified, the room that the patient is in, wherever they are. Gargle frequently with warm salt water, and eat soft foods to reduce pain. However, instruct the patient to notify the surgeon if the pain increases or there is an increased difficulty to swallow. Teach the patient the signs and symptoms of an infection, such as increased swelling, the presence of pus in any area of the oropharynx, a change in color of the mucous membrane to a beefy red, and increase in pain, the presence of a fever, taste changes, and the presence of bad breath. Instruct the patient to notify the surgeon immediately. Teach the patient regarding restrictive activities as ordered by the surgeon. However, the most common restrictions to prevent bleeding include lifting and performing the Valsalva maneuver, and this is holding the breath and bearing down. Psychosocial preparation. Patients using a CPAP, especially if they're wearing it for the first time, can become anxious. Therefore, provide the patient with written and digital instructions for the use and care of the CPAP. Also provide telephone resource members for healthcare professionals specializing in the management of OSA for supplies needed for long-term use of CPAP. However, usually the social worker will refer them to the social worker or case management, and they will get those supplies for the patient. Patients who had the surgery may also suffer from anxiety because they may be anxious about whether the surgery was successful or not. The nurse or healthcare provider would inform the patient that pain and difficulty swallowing are expected and should improve in about a week. They'll also inform the patient that snoring or sleep apnea may continue for a short time after surgery until all swelling is gone. What I would like you to do now is to complete, you can stop the tape now or do it at the end, but complete the NCLEX exam challenge 26-2 on page 521. That's health promotion maintenance. As usual, after we implement an intervention, we always have to evaluate. So these are the problems that the patient had, and we wrote these down. Just like you do your care plan, you write down what you expect, the expected outcomes for the patient, and then you evaluate. So these were the expected outcomes, and we're now evaluating these outcomes. So you're asking if the patient does not remain hypertensive or has hypertension that can be controlled with appropriate therapy. The patient is adherent with prescribed non-surgical interventions. The patient has fewer sleep time apnea periods of 10 seconds or longer, and also the patient has improved gas exchange with greater duration of restorative sleep. Patient has less daytime sleepiness and more energy. These were the outcomes that we wanted, the expected outcomes. Now we're evaluating them. Patient has an eventful recovery from surgical intervention. So we look on our goals. At the end, we evaluate them, and we will improve what did not work. So we look at it and see what worked, what did not work, and work on improving so that we can help the patient to have quality care. And so I'm going to leave you to answer this question. We did everything on OSA, obstructive sleep apnea, in part 1, so you should be able to answer this question. And I will see you in part 2.